Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Quick note before we begin, the Finding Genius Foundation, as part of the Finding Genius podcast, has recently completed a book about understanding viruses. So the creation of this book was to interview 100 virologists, ask them a lot of deep, difficult questions, take the most difficult questions, and then re-interview the top 25 or so and ask them the hardest questions I could think of. And we compiled that all into a book. So you'll see question and 4 or 5 experts' answers. Question, 4 or 5 experts' answers. There's about 30 questions in the book. I think it's a great read for the layperson and for the researcher. It talks about a lot of speculation in the world of viruses, such as are they alive or not, and why is it important? Why do viruses go latent or hidden or ineffective or sit in a person or an animal or another creature for weeks, months, years, and then suddenly become virulent and affect that person? So there's a lot of really provocative questions in the book. It's now on Amazon. So if you go to Amazon and type in Finding Genius, you'll see the book on viruses. It's also on Kindle. The Audible version is in production and should be ready in approximately a month. But if you want to go and order it now, you can do so again by going to Amazon or Kindle, or go to findinggeniusfoundation.org and go to publications. There's an opportunity as well to get the transcripts of all the interviews and to hear the original interviews themselves. If we put them all together, the book would be about 1,000 pages, but we condensed them down to make it juicy and concise and tight and very interesting. So I hope you'll check out the book. We're now working on one about cancer, but this is going to be our goal is 3 times a year to come out with these masterclass books that I think will inspire new scientific research, and I hope you'll check it out. Thank you.
Hello, this is Richard Jacobs with the Finding Genius podcast, part of the Finding Genius Foundation. I have Charlie Conway. He's the Chief Scientific Officer of Biohaven Pharmaceuticals, and we're going to talk about his work there. So, Charlie, thank you for coming.
Great. Thanks, Richard. Really a pleasure to be here with you. Thanks for the invitation.
Yeah, tell me a little bit of background on yourself and then how you came to Biohaven and what Biohaven's working on.
Sure. So my background is neuroscience, which means I study the brain. So I started in grad school. I studied brain development and how age-related changes in the brain affected the pain system. And my dissertation work systematically characterized maturational changes. That is, I showed that young animals have exaggerated responses to pain compared to adults, and that's because they have excessive pain connections and fewer inhibitory mechanisms. And what was really interesting was I showed that change matures in a top-to-bottom fashion, a head-to-toe fashion. So interesting that there are some ages where the upper half of the body is adult-like. That is, it's responding in the same way with less exuberant responses, but the lower half is still like a newborn. And then at a later age, it's all adult-like. So that's kind of how I started in grad school. Then my dissertation research led me to the postdoc at the UC San Diego Anesthesiology Research Lab, where I worked with Tony Yaksh. And out of that experience, I went into the pharma industry and led the research program for this new thing called CGRP, which I began work almost over 20 years ago, actually back in 2000, 20 years ago, started working on this.
All right, so that's what Biohaven's working on today is CGRP, and what is it? What's it about?
Sure. So for a long time, the basic understanding of migraine just wasn't there. Most treatments for migraine were borrowed from other diseases like epilepsy because it has to do with overactive brain cells and nerve cells. And so something that could sort of tamp that down was thought to be beneficial, but it really wasn't targeted therapy. So this is one of the first truly targeted therapies. So science and medicine have shown that the trigeminal nerve is the culprit in migraine. That is overactive. And when it's overactive, it releases CGRP. And this molecule, this brain chemical CGRP, is the short name. The long name is calcitonin gene-related peptide. And when that happens, it changes the way the brain responds to input, and it makes the brain hyperexcitable. So people who have migraine experience really disabling attacks that last from 4 hours to 3 days with symptoms like pulsating headaches, nausea, vomiting, hypersensitivity to light and sound. And it's not just like a bad headache. It's really very disabling. And there are about 40 million people in the U.S. that suffer from migraine, and it affects about 15% of the U.S. Population, and it's 3 times more frequent in women than in men. And so, go ahead.
Oh, did you any learnings from your old research, which sounds somewhat similar? About young animals getting overexcited and overstimulated.
Yeah, it was really interesting because early on, it was thought that these age-related differences, actually there was some misconception that the age-related differences meant that the undeveloped brains weren't fully able to appreciate pain, full pain state. That was called the Kennard principle back in the 1950s for a researcher, Margaret Kennard. And she came up with that principle because she saw that when young animals suffered an accidental brain injury, there was often no difference in adulthood. That is, the brain compensates. And so she proposed this Kennard principle that young mammals with undeveloped brains don't consciously appreciate pain. Unfortunately, this led to a bad practice of performing procedures on young newborns, infants with little or no pain management. For example, circumcision, something you'd never, ever think of doing in an adult. So, my work and the work of many others showed that this was wrong, that if anything, the younger have more need of effective pain management. And so the connection there was, I was studying a hyperexcitable state that developed into a more mature state. And so migraine is also a hyperexcitable state. So I agree there's a connection there.
So where does the trigeminal nerve run? What is, if I look at a person on the outside, where is it running?
Yeah. So if you look at the outside, and you kind of go like to the back of the jaw, this is kind of where the brainstem is. It's like deep in the center of the brain, and it's bilateral. There's one on each side, and that's where the cell bodies are. But nerve cells are like the tiniest, skinniest water balloons you could ever think of. That is, a whole cell can stretch for inches and inches across the body. So a single cell with its cell body in the brainstem can send up fibers that connect to the dural outer covering of the brain. And so that's where the inputs are. And then the outputs are in the brainstem in the caudal trigeminal nucleus.
So you can never palpate the trigeminal nerve or put pressure on it or anything from the outside of the body, right?
That's correct. You wouldn't be able to.
Well, what about a head position? If your neck stretches or your neck moves in a certain way, wouldn't that affect the nerve innervation? Either compromise it or facilitate it?
Yeah, so it's true, a basic principle that when you're having a migraine attack, activity exacerbates the problem. Lowering your head also exacerbates the problem. So there is some connection to sort of body position, head position, but it's more the consequence of making the symptoms worse in the event that an attack is happening, as opposed to being the initiating event of the attack.
Okay, so now that you know about the functioning of the trigeminal nerve, what happens? Does it get downregulated or upregulated? I would guess up. That's why everything seems like too bright, too loud, too intense.
So what we know is that when the trigeminal nerve is activated, it releases this brain chemical called CGRP, and it releases it in 3 places. It releases it in the dura, that's the tough outer covering of the brain. And when it does that, it makes the inputs to the trigeminal nerve hyperexcitable. It releases CGRP right around the cell bodies, and that also leads to what's called a neurogenic inflammation, which is just a fancy way of saying it makes the nerves themselves hyperexcitable to producing an action potential, which is how it sends a signal. And then the third thing is when CGRP is released in the brainstem, it causes the postsynaptic neuron, the nerve that's receiving the signal, to respond in an exaggerated way. So those 3 things together are part of this excitatory symptomatology, but it leads to actually what we think is changes deeper in the brain, that is in the thalamus, which is like the sensory relay station of the brain. And we say that because it's not just the pain signals that come from the trigeminal nerve, it's sensitivity to light and sound, nausea. Also, people have hypersensitivity to taste and smells. So, it's a more general thing. And so what was happening is that exaggerated trigeminal nerve activity is actually changing the response properties deeper in the brain.
So why would the trigeminal nerve produce the CGRP? What's the reasoning behind it, you think?
Sure. So all pain-sensing fibers contain calcitonin-related peptide, or CGRP, and it's just part of the signal that occurs when you've got persistent pain. If you have just an acute pain state, like if you prick your finger, that releases excitatory amino acids like glutamate and aspartate. But if you have ongoing high frequency activity, that's where the peptide CGRP gets released. And it's a signal of hyperexcitability, or it's a signal of having a sensory input being in overdrive.
Before we continue, I've been personally funding the Finding Genius podcast for 4.5 years now, which has led to 2,700 plus interviews of clinicians, researchers, scientists, CEOs, and other amazing people who are working to advance science and improve our lives and our world. Even though this podcast gets 100,000 plus downloads a month, we need your help to reach hundreds of thousands more worldwide. Please visit findinggeniuspodcast.com and click on Support Us. We have 3 levels of membership from $10 to $49 a month, including perks such as the ability to see ahead in our interview calendar and ask questions of upcoming guests, transcripts of podcasts you're interested in, the ability to request specific topics or guests, and more. Visit findinggeniuspodcast.com and click Support Us today. Now, back to the show.
Now, the quandary here is, while we know that CGRP gets released during a migraine attack, we really don't know what the triggering event is. That is, the triggering event is not the same thing for all people. So for some people, migraine trigger is stress. And, stress related to the pandemic only exacerbates their migraine disease. For others, it can be foods and different things. And so lifestyle changes are recommended, and, new treatments are coming available.
So the function of CGRP is when there's pain, for the body to recognize it and do something about it as a warning signal, or what's its biochemical function?
No, exactly. And so usually pain is your friend, right? Because it warns you of impending tissue damage or injury. It becomes maladaptive or not helpful when it's going on constantly, even in the absence of any injury or stimulus that you need to avoid. And that's the situation in migraine.
What happens when you study normal pain? Like if someone bites my finger and it hurts, will my CGRP be upregulated just in the vicinity of my finger, or is it in multiple spots in my body?
Yeah, so when it comes to like your finger, that has the same kind of a sensory input, and it sends a signal to the spinal cord. If it's brief pain, it's just the fast-acting transmitters, which are like aspartate and glutamate. If it's a persistent pain state, it's the slow depolarizing effects of something like CGRP. And the difference is this. When it's acute pain, it's a 1-to-1. So think of a pinch sends one signal. But when it's persistent pain, the signal that happens at the level of the spinal cord and up to the brain can be like 1 to 10. So let me give you an example. If you whack yourself on the thumb with a hammer, when you whack it, it hurts like heck. But the next day, if you happen to walk by a table and you brush your thumb on the table, that brushing of the thumb also hurts like crazy. Well, that's normally not a painful thing. So normally it's not painful to lower your head. Normally it's not painful to have bright lights. But after this exaggerated CGRP release, it changes the response properties and puts you in this hyperexcitable state.
So this response is more reminiscent of a chronic pain response, but it happens acutely and suddenly, which is strange.
Yeah, it's unpredicted. Some people get like a visual sensation or a visual disturbance. It's called an aura. They know it's coming on. And, if you talk to physicians, what they've said to their patients is, it's really best to take something as soon as possible, as soon as you know that something's coming on, because the longer you wait and let it sort of build up, the harder it is to control.
So does this give you any insights into why migraines happen? Has anyone figured out why they happen and what are the multiple factors that cause them?
So, we know there's a genetic component. For example, if you have one parent that has migraine, you have a higher likelihood of having migraine. If you have 2 parents that have migraine, you have an even greater likelihood of having migraine. So, what we can say is there's definitely a genetic, a family-related component. What we don't know is, why or what's different about those. What we also know is if you measure the baseline levels of CGRP, so let's say that you are not a migraine sufferer and I'm a migraine sufferer. If we compared the plasma levels of CGRP between you and non-migraine sufferer and me, then my CGRP levels all the time are somewhat higher. And so it's kind of like I'm closer to the edge of throwing the switch that leads to the migraine attack all the time.
Oh, so people that get migraines, constantly in this state of ready to produce CGRP when other people, they have a much higher threshold, let's say. Is that accurate?
That's right.
So what are like some of the precursors that make CGRP, or, has anyone, again, really looked into what could be causing this? Why is their set point different from other people?
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
Yeah, you're really talking about science that has yet to evolve. The big dramatic thing that's evolved over the past 30 years is that instead of having therapies that were targeted at other disease states, now we have CGRP-specific therapies. So we've got anti-CGRPs, and there are kind of two groups of those. One are oral. These oral anti-CGRPs block the receptors, like putting tape over a keyhole. The key can't get in the hole if there's tape in it, right? And so those GPANs, like Nerdtech is an example of that, Nerdtech ODT, it's an oral CGRP receptor antagonist, and it's been shown to be effective in the acute treatment of migraine. There are also a class of anti-CGRPs that are injectable. These injectable anti-CGRPs are monoclonal antibodies, and so they circulate in the body, and they work in one of two ways. There's one that also blocks the receptor, and then there's three that act more like a sponge to soak up the circulating CGRP so that it can't get to the receptor. And so those treatments are new targeted treatments. And what's been exciting in this space is we've shown now that the treatments are effective for both acute treatment of migraine as well as preventive treatment of migraine. And that's important because in the past, there's never been sort of a unified hypothesis that could explain migraine. We have one set of agents for acute treatment and a different set of agents for preventive treatment. So, for example, the triptans. Almost 30 years ago, in 1992, the first triptan was launched. And that was the mechanism of action was a serotonin 5-HT1B1D agonist. And what we didn't know at the time, but we know now, is one of the properties of that is it actually inhibits the release of CGRP. So it may be that most of the functionality of the triptans are actually acting through their secondary effect on CGRP. The problem with the triptans is they're active vasoconstrictors. So if you're a patient who has a history of cardiovascular events or a condition or a procedure, then you are someone who actually shouldn't be taking a triptan. So the beauty of the anti-CGRPs is you get all the benefits of the triptan without the side effect profile or the baggage of the triptans.
When people get migraines, can they sense it's coming? Or is there only a subset of people that can? Other people, it's like, oh no.
So there are two different diagnoses. So one is called, migraine. The other one's called Migraine Aura. And so in about 40% of people, they get this sensation that something's coming. They get this aura. And for a lot of those people, it's a visual sensation. There's a change in their visual field or actually an abnormality in their visual field that they can see. And others have different experiences, but can also sense that there's an attack coming on.
So I guess the preventative, if used by people that can sense it's about to hit them, as long as they're qualified, they don't have high blood pressure or other heart ailments, can they use these triptans in that way? Just they start to feel something's they're gonna have a migraine. They take it right then and it prevents them, or do they have to take it just every day chronically, just like as a medicine, regular medicine?
Yeah, so the triptans were only ever approved for the acute treatment of migraine. They were never approved for the preventive treatment of migraine. So that class of agents is one of the reasons that led to sort of this bifurcation in how we thought about the disease. That is, we thought about the disease in two ways. That is, that if people, had, attacks that came on that needed to be aborted, then we called those people, some people who need acute treatments. If they had high frequency or ongoing attacks that were so debilitating, then we thought of those people as, needing preventive treatments. But that led, unfortunately, to the idea that there's a disease, called episodic migraine that needs acute treatments, and there's a disease called chronic migraine that needs preventive treatments. But that was only because those were the only tools we had at the time, right? So there's this long history of thinking about migraine as two different things, when actually now science has advanced, and with our new scientific understandings, we realize that the underlying physiology is not different. That is, people who need acute treatments aren't fundamentally different from people who need preventive treatments. It's just the tools that we've had in the past could only do one thing or the other. And so the dramatic thing that's coming forward that's changing is that the oral anti-CGRP gepants has shown that this mechanism, blocking CGRP, is effective for acute treatment. The injectable CGRP antibodies have shown us that the anti-CGRPs are effective for preventive treatment. But now, with Biohaven's 2 publications in the Lancet, we have rigorous scientific data showing that Nerdtech ODT can do both. And so if you need acute treatment, why not take the acute treatment that can help prevent your next attack? And if you need preventive treatment, why not take the preventive treatment that can also provide effective acute treatment? So that's the unified sort of approach that's beginning to emerge. And currently, Nerdtech ODT is under FDA review for preventive treatment. And if approved, it would be the first ever molecule, the first ever medicine in the world to be approved for both acute and preventive treatment of migraine.
How does chronic pain subside? And what's going on biochemically when chronic pain subsides? What happens to the CGRP? Is it just used up? Or is it then did the levels drop for some reason?
Yeah, so if you track sort of the arc of a migraine attack, for some people, the migraine attack is fading, at 4 hours. For other people, the migraine attack doesn't fade until 3 days. What's similar about all of those is that you see the CGRP levels rise and fall over those same periods of time. So it's kind of personal, person-specific. If you're someone who has a history of getting, X number of attacks, let's say 4 attacks per month, you kind of are in that same pattern. If you're somebody who has a history of 9 or 12 attacks per month, you kind of are in that same pattern. And, the sort of the dropping off or the changing, there's a couple things that go on. So in the body, there's these endogenous inhibitory mechanisms. So when a pain signal starts coming in, the brain actually sends a responsive signal down to sort of quash that signal, to sort of shut that signal down. Now, when it's so severe, the brain can't overcome it, and then you're going to have an attack, and it's not going to be able to overcome it. In terms of, why does it fade away or how does it go? There's actually been less sort of specific studies around that. You could postulate that there's only so much CGRP available and it gets, depleted, but nobody's actually nailed that down. It's been more describing what's happening. And so to me, that's one of the things exciting about neuroscience and brain diseases is there's still more to learn. And the exact underlying reason behind that is something that we've yet to learn.
And how do you measure CGRP? Do you do a blood test or saliva? And is it just localized or is it systemic, the reading?
Yeah. So, where you'd really like to do measurements of CGRP is right there in the brainstem, because that's where the trigeminal nerve is releasing CGRP. So that's not been the way it's done, of course, because that would be very invasive and would require an operating room procedure and anesthesia and all this kind of stuff and potential damage to the patient. So you wouldn't want to do that. So what we do instead is we measure blood levels of CGRP. But when you think about it, it's kind of like you're picking up, pennies for a rich man's pockets. You're just getting, the very distant effects. Kind of like if you dropped, a drop of red food coloring, in a swimming pool, it can still be there, but the farther you get away from the original drop, the less intense it is. There are a couple researchers who have done some work looking at saliva. So that's an interesting additional way that we might measure it. If it's shown to be reliable and repeatable, then that could be, sort of a good way of assessing patients who sort of have a CGRP-mediated migraine attack. Today, it's really done by trying the prescription that you get. And, if you test a half a dozen attacks and something doesn't work, then your physician will probably tell you about, well, your attacks must be driven by something else. And so they'll try something else.
Okay, so you're working on this new drug that's going to help both acute and chronic migraine sufferers. Is that right? Like how far along is it? And tell me some details.
Sure. So Nerdtech ODT, this is the drug that came out of my lab along with the chemist Jean Debochik and a whole group of other biologists and chemists and safety scientists and pharmaceutics folks. It's a marketed product. It was approved for the acute treatment of migraine back at the end of February 2020. We launched the same week as the global pandemic shut down. So that was a new twist that we didn't see coming. But it's been on the market now since that time. And it's really been making a big difference. We get about 1,000 social media posts every week from patients who we didn't even ask to post. They're just saying, this is so different from my usual drug. I needed to tell you about it. I've got my life back, or I've got my career back. And so the other thing that we did in addition to studying the acute treatment of migraine, and the difference is this: when the FDA approves a drug for acute treatment, you have to hit a 2-hour endpoint. You have to show that it makes patients pain-free more than placebo at 2 hours. And you have to show that it treats their most bothersome symptom. And by most bothersome symptom, that is either nausea, hypersensitivity to light, or hypersensitivity to sound. And so if you can do those at 2 hours and show a statistical significant difference from placebo, then you can get an acute treatment for migraine indication from the FDA. And that's what the oral GPANs have. And so Nerdtech ODT is an oral GPAN. Now, for the preventive treatment of migraine, it's a totally different story. There, you watch patients for a month before they get drug, and you look at how many attacks, how many migraine attacks or migraine days or headache days do they have in that 30-month baseline period. Then you treat them for 3 months, and you look at how did that treatment change their response. And so for effective treatments like the anti-CGRPs, you get about 50% of the patients showing a 50% or more reduction in headache days. So, for example, if you're somebody who had 8 headache days before, then now you have 4 or fewer headache days on that preventive treatment. And so currently, because we have a longer half-life, so Nerdtech has about a 12-hour half-life, what that means is it takes 12 hours for half of the drug to be eliminated in the body. And usually it's about 5 half-lives for a drug to be gone. So 12 times 5 is 60. So that's a little over, 2 days it would be in your system. So we studied in a prevention paradigm. We took an oral GPANT and we studied it just like the injectable CGRPs did for prevention. But because we have this long half-life, we didn't ask people to take it every day. We only asked them to take it every other day. And with every other day dosing, they showed the same signal that you see consistent with the GPANs, which isn't surprising. It's the same underlying mechanism. So that study is what's currently under FDA review, and we're on track for a 2Q, that's this current quarter, 2021 decision from the FDA. And on positive data, it would be the first agent to have that dual therapy indication.
So you were talking about symptoms for a minute. You said sensitivity to light, nausea, obviously the headache, etc. So there are different types of migraine sufferers where some will get a lot more nausea and a lot less headache, or some will be very sensitive to light, but they won't have nausea. And if so, what's the implication?
Yeah, that's exactly right. So there's a lot of diversity in that. Some people, it seems to be they have a certain migraine phenotype. And by phenotype, I mean they have a fingerprint. If you're somebody who gets nausea and vomiting with your migraine, it's almost every time. Or if you're somebody for which hypersensitivity to light is one of your major symptoms in addition to the head pain, then that seems to be just characteristic of what you have. There is some patient variability from patient to patient, but it seems like each patient kind of has their own migraine fingerprint. That is, the excess CGRP is laid down on top of who they are and what their body physiology is in a way that different people experience different types of sensitivities. And so if you look at the International Classification for Headache Disorders, they have like these set of criteria for migraine diagnosis. And it says things like, one or more of the following, or, one of these 3 or whatever, because they recognize the variability in how each individual patient can express a migraine attack.
What's next? I mean, I would think you've gotten a lot of data, hopefully on Nerdtech. What are you seeing from the data that surprises you, or does it just perfectly align with what you expected?
Yeah, so I think, the data that surprised us would be how quickly it could come on with the ODT. We knew that the oral dissolving tablet, so the importance about an oral dissolving tablet is it doesn't need water to be taken, right? And so people who have nausea, they love that, because the last thing you want to do if you're nauseous is try to drink something, right? So just being able to put something in your mouth and have it dissolve, that's a great thing. Well, we knew we had a faster rise of drug to the maximum effect, which is called Tmax, with the oral dissolving tablet than with a traditional oral tablet. And what that translated to us is a more rapid onset of action. So if you look at our publications in The Lancet, you'll find that we have 60-minute pain relief. That is, patients went from severe or moderate pain down to mild or no pain. And we also have 60-minute return to normal function. That is, patients saying, I'm all the way back to normal. And so that occurred really quickly. And then we also saw that a single dose of Nerdtech can start working in minutes, but also last for up to 48 hours with few side effects. And so that long duration of action, that 48 hours, was a pleasant upside in terms of the profile of Nerdtech ODT.
So what's next for the coming year? What do you see as what needs to be worked on? Just keep rolling it out, or what else?
Sure, yes. So, we've launched in the U.S. We're starting to do worldwide work, in the acute treatments. We're pending this FDA approval for, preventive treatments. And really, I think, the future of migraine treatment is we're showing that we don't have to think about migraine as two different things anymore. We can take a unified approach and potentially treat a single disease with a single underlying pathophysiology with a single medicine. So one disease, one treatment kind of approach. And so, that's sort of the potential paradigm shift that's coming. Another future thing that's already here is that the side effect and tolerability profile of the anti-CGRPs is really, in general, much more tolerated than the old treatments. So, I think what patients and physicians need to think about is, particularly with patients, if this sounds like if you have, unpredictable pain, headaches, and you also have nausea and you're sensitive to light or sound, or you get a premonition that's coming on, or you have hypersensitivity to touch or, taste or smells, if that sounds like you or somebody it would be a good idea to have a conversation with your doctor, because unfortunately, less than half of patients are diagnosed. And so, the important thing is to understand that there are new treatments available. These anti-CGRPs are available, and people have a chance to sort of take back their life in a way that looks to be more tolerated in general compared to the sort of older treatments. And there really hasn't been any innovation, Richard, in the space for nearly 30 years since the onset of the triptan.
When you say the old treatments weren't tolerated, what do you mean? What would happen?
So if you look at patients who took, triptans or dihydroergotamine, the earlier treatments for migraine, and you checked in with them a year later, 35 to 55% of patients weren't on the drug, either because they didn't work for them or they couldn't tolerate them. So there's treatment emergent adverse events and tolerability issues where they had chest and neck tightening from the muscles, from the vasoconstrictive effect of the triptans, or they weren't able to think clearly, or there's something actually called medication overuse headache. Richard, this is the worst thing. This is, if you take one of these older acute treatments more than 10 or 15 times per month, it actually increases the number of attacks that you have. It's called medication overuse headache. The anti-CGRPs don't have that profile. So it used to be that doctors who were prescribing triptans would say this to their patients. Let's say you were a patient, Richard. You'd say, Richard, here, try this drug. Take it as soon as you feel an attack coming on, but don't take it too often. Well, that would just make people crazy, because now they have to decide, is this a triptan-worthy attack? Or do I try to get by with something else like an over-the-counter medicine? With the anti-CGRPs and the GPAs like Nerdtech ODT, patients aren't put in that quandary. You don't have to trade off, benefit for baggage, and you don't have to worry about your drug producing an increase in attacks. In fact, in our long-term safety study, we saw the exact opposite. People who intermittently used Nerdtech actually showed a decrease in the number of attacks per month. And that's what led us to do the preventive trial that we wrote up in the Lancet that's currently under review by the FDA. Yeah,
that's really cool. You don't want a pain in the head drug to turn into a pain in the ass, I guess, to make a bad joke.
There you go.
Well, very good. Where can people get Nerdtech? Do they just speak to their doctor and the doctor will prescribe it to them, or is it over the counter?
Yeah, so it's prescription only. So, and just a comment, individual results will vary. The most common side effect among about, 2% of the people taking Nerdtech was nausea, compared to 98% of people who didn't get it. And for more information, people can visit nerdtech.com and find out all about it. It's a quick dissolving tablet, which means you don't have to take it with water. It also means you can be discreet. I saw a scientist give a presentation, and he said, did you notice what happened during my presentation? And people were like, what are you talking about? He's like, I took my Nerdtech ODT, and nobody had seen it. And actually, migraine sufferers don't like drawing attention to themselves. They're tired of being looked at as people who are the ones who aren't carrying their weight because they miss too much work or they're not able to show up for family events. So it's really an opportunity to take back control, and it's an exciting time. So I would say if you're a sufferer and you haven't tried one of the new treatments, definitely this is a good time to talk to your doctor. There's been little innovation for 30 years. So I encourage people to do that.
That's great. Well, Charlie, thank you for coming. You want to give a website or any other reference for people, or just, again, if you're listening and you have these problems, just ask for Nerdtech.
Sure. So nerdtech.com, NURTEC.com.
Very good. Charlie, thank you for coming on the podcast. I appreciate it.
Great. Thanks so much, Richard. Appreciate it.
If you like this podcast, Please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.